All right, we're live. So good morning, everyone. This is Senate Health and Welfare Fair. And it is April 3rd. And it's a good thing that we're here in the morning because it's going to snow in the afternoon. Anyone who needs to leave early is going to have to think about that. Tomorrow morning will be much better, but we'll still start right at 9. Okay, so this morning we are looking at H766, getting some testimony from folks. And this will be really our first day of full testimony. We'll have more testimony going forward. And then we'll also be looking again at H847 and hopefully get to a good place with that bill. Maybe by the end of the week, we might be ready to act immediately. So this morning, Julie Lynn is here. Are you here? Good. Why don't you come up and we're going to introduce ourselves once for everyone in the room and also on Zoom. And then as you come up, you can introduce yourself for the record. That'll be helpful. So, Senator.
Good morning. Good morning. Senator Martinez Rocky from Burlington. I represent Chittenden Central.
Good morning. Dave Williams from Proctor, representing Rutland County.
Ginny Lyons representing Chittenden Southeast.
Gary Williams, representing Rutland County from Fulton.
Good morning. I'm right on time. I'm Senator Ruth Hardy from the Addison District. Hey, wait, I sat down.
I was late, so you must
So we're good. And thank you, Dr. Lynn, for being here. So why don't you introduce yourself for the record?
Okay. My name is Julie Lynn. I'm a physician. I'm board certified in dermatology and clinical genetics. And I am currently an independent community dermatologist in St. Albans. I did a practice in Petition, Vermont for about 15 years. So I was prior on faculty at UVM. And for the past 5 years, I've been in the community practice in St. Albans. And I'm a Health First member, former board chair, and a member of the Vermont Society, also VMS board member. Okay. Should I
Just go right ahead with your testimony.
First, I want to thank you for the opportunity to speak. And my understanding is I'm here to kind of give the background and set the background of why we're talking about this. So I am the only dermatology practice north of Chittenden County. I'm a practice of 2 physicians, so very small. It's small enough that only one of us can be in the office at the same time. And we provide care to a large geographical area that's an underserved population for dermatology. So we have patients that travel hours to see us from out of state, northern New York, all of northern Vermont. People from Canada come down to see us. And our wait times are very long for dermatology in general across the country, and as it is up there. So new patient appointments in the entire state are about 4 to 5 months. Unfortunately, in the past month, we had to close our patients to new patients, our practice, because we can't take the volume. So we only have a walk-in clinic on Wednesday mornings people can come in. So if our office doesn't survive due to the administrative burden, patients that need dermatology services are going to have to travel to Chittenden County for care, unfortunately. So I'm going to give an introduction, basically, current landscape. And feel free to ask questions or interrupt if not clear. So I'm basically here to discuss the administrative burden of insurance billing and impact it has on patient care. And this contributes a lot to physician and provider burnout, especially in a state where there's already a shortage of providers, but you don't want other people leaving because of what's happening. So there's no one standard way to get paid. Each insurer has their own processes and policies, and each year it gets more and more onerous to keep track of the changes and abide by the new rules. So it's been a national trend for insurance companies to implement additional software to automatically perform something called claim edits, which I'll kind of explain as I go along. So claims editing is a process of reviewing claims for coding, validity, and accuracy. And they're often processed through computer algorithms that automatically flag claims with specific codes or modifiers for review. And they either lower payment, withhold payment for various reasons, depending on the policy of the payers. And sometimes payment is even withheld until a copy of the medical note is submitted and deemed appropriate, justified use modifier, and then you're kind of paid. If it's denied, sometimes there's an opportunity for what they call reconsideration, but ultimately the final decision is made by the insurance company. If they say, we don't think you should get paid, you don't get paid. So, you know, as I mentioned, ultimately, if the claim's denied, the physician just doesn't get paid for their services. And that's why the contract allows them to do that, unless you ask the patient to sign what we call an ABM, advance benefit of notice, saying if the insurance company doesn't pay, the patient won't be paid. We can't seek payment from the patient. Okay, so that's kind of set the background of what we're talking about. So I'm going to give a basic coding and claims process 101, so that's when other people speak. And how many, are you familiar with claims code? Okay.
So
I wanna speak to,
I would say if claims code 101. Not everyone here is familiar.
Okay,
And
so I'm
it
just
doesn't
gonna,
hurt for some redundancy.
okay, so I'll start from the beginning, and if I'm not clear, please stop me. So I'll go from the beginning. So when a patient is seen by a physician or provider, I see the patient, I do exam based on the clinical services performed and what you do and what you document in medical record. The services translate into a 5-digit code called a CPT code. And the CPT code stands for current procedural terminology. And it's a book that's about big as an old telephone book. In the old days, you would look it up. Now there's a lot of online databases or something you purchase. A lot of it that's embedded into the EHR. So based on that, you choose a CPT code. And these were developed by the American Medical Association. It's very detailed and standardized description of every medical procedure that is performed in this country. So you can look up the book if you go to the AMA website that describes it. And then there's a subset of these CPT codes that are called evaluation and management codes. We use the word E&M for short. These are the most common types of office visits. So some examples of common codes are 99202, which is a office or outpatient visit for evaluation management of a new patient. There's 99213, evaluation management of an established patient. And they all have descriptions about which requires medically appropriate history and or examination and low-level medical decision-making. And if you're using a time code, you can use 20 to 29 minutes, total time spent. Dates, like every code has this paragraph description of what qualifies for it. So then in addition, you can add a modifier being added to a CPT code. So a medical coding modifier is usually 2 characters, letters and numbers, such as 25, 59, 50, and that's appended to a CPT code, and that provides additional information about the medical procedure, service or supply provided. For instance, if you did more than one procedure, if you did a procedure on the left or right side, you have to designate left, right, or bilateral, whether you did telemedicine. And some specific modifiers that I'm going to mention today is a 25 modifier. So that's when you add that when there's a significant, separately identifiable evaluation management service that's provided by the same physician or other qualified health professional, same day first procedure. 59, we would add when a distinct procedural service is offered on the same day. Okay, so I'll go into some examples, so just giving you a background. In addition to that, when you see the patient, you also have a diagnosis code, which is a separate big book of well, not every diagnosis, but a lot of diagnoses called International Disease Classification of Disease, so ICD codes, which the original purpose of this, if you want to historically, I think it's the WHO that created it to really track mortality. So they kind of use this already existing definition for different purpose. Coding was never intended for this. And then you put a diagnosis with every visit to explain the diagnosis and sort of the patient, why they needed any appointment or procedure. And that's maintained right now by the National Center for Health Statistics. An example of ICD-10 codes are C44.321, that's squamous cell carcinoma of the skin. You could have D18.01, hemangioma of skin, subcutaneous tissue. These are also codes that you used to have to look up. These are all in most of the electronic health records. So then, once the codes are submitted, or the service is provided, typically now a physician will put the codes in the electronic health record and modifier to match everything up. And then they're packaged and they're submitted, and the payer compiles them into what they call a claim. And this claim contains all the CPT codes, relevant diagnosis code for the services rendered. And the claim is sent off to the patient's insurance company for payment reimbursement. And then the insurance company checks the claim, checks for errors, verifies everything's okay, processes it. And then if it's okay, they pay the the doctor. So insurance, so basically in summary, medical billing involves translating what I do as a healthcare provider into these special codes and then compiles them to a claim and then sends to the insurance company and hopefully get paid. And the turnaround time is there days, weeks, sometimes even months. There's always a lag in this reimbursement. And I just think with the time that has it's getting worse and worse. So in terms of my personal experience, we're a small office, 2 physicians. One example is, a typical visit is somebody comes in, they have a rash. You want to know, what is it? I come in, look at them. That's my evaluation management. We've got a lot of things going on. Sometimes I'll give them a diagnosis of psoriasis. We talk about the condition, what treatments are. I order some labs, order medication, prescription. That's an office visit. But as I'm looking at their skin, I'm noticing something suspicious on their chest. Looks like a skin cancer. I'm worried enough that I don't want to leave it on the person, so I will do a biopsy. That's another CPT code, procedural code. And in addition, I'm seeing some precancers on the nose, or maybe they have a wart. So I treat that and I freeze it. So that's a very typical bread and butter office in dermatology. So I coming in for evaluation of the problem. They also need a procedure, a biopsy, and then a second procedure, which is a freezing. So then I would put a E&M code, which is for the office visit, CPT code for the biopsy, CPT code for the destruction of a benign lesion. And then on the office visit, I would put a 25 modifier. On one of the procedures, I would put a 59 modifier, which signifies I did an evaluation management for psoriasis, did a separate evaluation management for this suspicious lesion, where I did the biopsy, that's the procedure, and then another lesion that I fixed. So that's just a lot of what we do. We're very procedure heavy. So being a small physician with 2 physicians, we have a very small operating margin. What that means is that if there's a long delay in insurance reimbursements, it's really challenging. Like right now with healthcare, which is not next week, but like it's been over 6 weeks, and there's no money coming in, it's starting to get a little bit tight. But that's how offices are. So we run very lean. We have no office manager. We don't outsource our coding and billing. We do our own coding, and we train some more staff to do billing to drop the charges that we put in. And it's really just all the reasons of 2 doctors and very dedicated staff of 5 people. And we now have 2 virtual assistants that help us with the coding and billing. So typically in the past, when we submit a claim, it's reviewed and then you usually get reimbursed. And what happened with one particular insurer was Blue Cross Blue Shield is there was communication about they were implementing a new claims editing software, which is basically a new computer program where they were going to make sure we are coding and billing appropriately, which is reasonable. Like they want to make sure what we're doing is accurate. But the new process, the communication that came out was a pretty thick document. I think, it didn't come to me directly, it came to our office, and we looked at it, but I think we didn't quite understand the implications until it got turned on. So then what happened was, instead of getting paid, anything that with the 25 or 50 mile modifier was automatically held. And for our specialty, that's a lot of our business. And instead of, in typical places, you get payment, if there's a question or audit, you would then send a note, they would review it. If they felt it was inappropriate, then you would have to reimburse or pay back the insurance company. Now, you just weren't getting paid. So automatically 25 modifiers were held and you had to send a note and kind of prove that what you did was appropriate. And the volume in our office was pretty high. So the process in the beginning was very slow. You couldn't bundle it and say, okay, these 20 patients, let's print out the notes, send it off. We had to send them off individual emails, one by one. And our electronic health record didn't talk directly to Blue Cross Blue Shield, so we had to print it out, scan it in, give a client email, one by one, and it really clogged. So we weren't getting paid for a while, significantly delayed, and it was very hard to track. We use a very small software program. We don't have those type of robust data analytics. Say, these are all the ones waiting to pull. This is one we sent, this is what we're waiting on. Really difficult to track. So unfortunately, we are trying to figure out how we're going to survive. So we made a very difficult decision, and we were very upfront with our patients and say, look, I want to do everything here for you today, but if I do all of it, there's a chance there's gonna be a huge late payment or we might not get paid at all. And if they live local, he said, if you're willing, you can come back another time, we can do the procedure then. If by doing that, because you're not putting a modifier, you would get reimbursed more timely. And a lot of the patients were really gracious about this. We're not doing this anymore in a short period of time because we just had to pay our bills, we had to pay our staff. And it was too much for us as a small group. And that's kind of what we were talking about, the operating margin, we just couldn't tolerate the delay in payment. And this flips like the typical insurance payment on its head. So you, like I mentioned, you typically get paid for the code you submit, and there's a question of improper billing. The insurance company then will do an audit and recoup any incorrect payments. And instead, just every claim is just with certain modifiers is held automatically because it's a computer program probably doing it. So, you know, our wait times are already very long for specialties, so having to add these additional visits for procedures, it took away visit slots for other patients. And honestly, we were just double booking these patients and running late. So that's kind of what I'm here to explain about that. So, yeah, the claims editing process put us in a really difficult position of like needing to do the right thing for our patients, making decisions for the survival of the small office. And, you know, we want to give high quality care for the patients. That's central to our mission, not to have to be concerned about, am I going to get paid or not? So if I see a patient, you know, with a melanoma, I don't ever want to delay procedure because of the administrative burden. And that's kind of what I'm here to explain about.
So how many insurers do you have to do that for?
Right now, as far as I know, Blue Cross Blue Shield, but since that time, because when we asked, why are you doing this? The answer was, we want to make sure people are coding appropriately. I said, that's very reasonable. As dermatologists, at least, we always take coding classes as CV. Like when the new coding went out, I paid for a 1 or 2 day course and I sat for 8 hours listening to coding, making sure. And when it started, my colleague and I, first day, we clinic, the coding went, we compared our notes and we pretended to code each other's visits, made sure it matched up, asked colleagues. So, you know, I felt we were very confident, very well educated. So they actually offered, because we were a small office, to do an audit of our office. So we gave them, I think, 30 random notes. Coder came. We were fine. We were not coding inappropriately. So
that was my next question. I don't know how successful were you in providing the codes accurately?
as far as I know, they told us we got an email from the nurse coder. We didn't have any errors. So it was to me, it was a lot of unnecessary burden for us. And this happened over about a year, but this is still happening in other offices. Like I don't know who is or isn't. I know they look at offices. I mean, I think Blue Cross Blue Shield can speak to that we're not high users of this modifier, and they were communicated they weren't going to get the automatic audit, and they eventually offices would be taken off the list.
Okay, so let's do a couple questions.
Yeah.
Thank you for your testimony. So the bill that we're considering it's the prior authorization bill that we're working on right now. It was late, so
Yes.
but I'm trying. Okay. So the codes that the 59 and 25 you mentioned, was the issue that you think Blue Cross was trying to get at was whether or not you had the authorization to provide those services on the same visit that you were doing something else?
I wouldn't say authorization. It's pretty standard coding that if you do an office visit, which is a CPT code ERM, if you do a separate procedure, you append it with the 25 modifier to flag to say, I did a separate independent E&M. I did a procedure.
I mean, it seems
It's nothing to do with the prior occupation. That's
okay.
more like
So that's what I'm
medication.
trying to figure out with the bill is that if we were to pass the bill, would this situation that you just explained be better? I see people nodding behind you, but
So I'm gonna say I have not read the entire bill
Okay.
for words. So
You're,
I'm
you're
gonna
a doctor,
defer,
not a,
I'm gonna defer to
okay.
all colleagues in here.
She's
Okay.
our background person.
I'm
I know
the
that's super
background
helpful,
person.
it's super helpful to hear what you have to go through,
Yeah.
and I can hear your stress as you're
Yeah.
explaining it all.
Yeah.
So, and if we, and you might not be able to answer this either, but if we were to pass the bill, do you think it would decrease the number of administrative people you need? Like you said, you have two sort of remote coders or something, or two,
I mean, we had to hire an extra person because this happened.
right?
Could not keep up with the back and forth.
So if we were
that we
to
had.
pass the bill and reduce this, do you think you would be able to save in administrative costs in your practice?
I would hope so, if it's less back and forth. I mean, I would rather be paid for my services, and if there's a question of whether we didn't code properly, they then ask for the note, and I would give them the money back if they didn't think it was perfect.
Mhm.
But I would rather get paid up front and not wait months.
Right, payment, because you're such a small practice.
Yeah.
And, I mean, it does seem like having somebody, as a patient, I appreciate, if I'm gonna go see a dermatologist and they can take care of all the things in one visit and I don't have to drive back
Yeah.
up to your place. That seems more efficient. It's saving
Absolutely.
patients
It's all about
time.
patient care.
It's saving patient money,
Mhm.
and stress too.
Yeah, you
You
should
don't
have to take an
worry about
extra
the
day
thing.
off of work, they have another
Yeah.
copay, it's just not,
Yeah.
it's not practical, it's not reasonable, it's not right.
Mhm. Okay, well, I would like to hear like directly.
We'll
how
hear,
Bill might
we'll
help,
hear.
So, but thank you very much.
But we're, Senator, we've got a whole long
Yeah,
list
sure.
and then we're, we're good.
I feel like other people are gonna be able to speak
Yeah.
better to your question.
Okay.
I'm gonna defer to other people.
So I'm gonna ask a question, then Senator Williams has a question, and that is, do you have your testimony in writing that we can put on our webpage?
Yes,
Good,
I can-
perfect, that's good,
Send it
just send it to Kiki.
Okay.
That would be great. And Senator Williams, you have a question.
Well, thank you for your testimony. I've experienced this, heard from constituents, I've heard from, clinics, clinicians. And, you know, and that, when you hear it from the top and you hear it from the bottom, that somewhere in between, you start to formulate your own opinion. We'll try and keep that out of it, but if I can just say my opinion right now, probably it's this government's problem that's causing all this. But I understand, I had over the holiday, I had a cousin of mine that came to me and said, this is a very technical field, because he's actually taking courses.
Oh, they're certified
medical
coders
coding.
and billers
There's
that
a
big offices have,
Right,
yes.
so we've created another, level to fix it, and you're doing it out of your time, so. So I appreciate it.
In a lot of medical centers, the provider they put the code in first, the first pass, but often there's a professional coder that double checks. I mean, I would say that I did part of my training in Canada, my Canadian colleague, they look at me bug-eyed, like they don't even know what it is.
Right.
You just submit it, you get paid. There's no like
Well,
coding modifier this.
Because
that.
you're an expert, you're trained to make those decisions? Because you're
Yeah,
a
there's only you-
clinician trained to make those
You
decisions.
only know what you did,
Right.
right? And the note is the record of what happened. So a coder can look at your note and decide what the best code is. And it's both ways. There's people who don't code at all, coders or there's many common.
Thank you.
Thank you.
Thank you. No, thank you very much. Senator, any questions?
No, thank you.
Okay, thank you very much.
Yeah.
And so if you can get us your testimony, we'll have it.
Okay.
And it'll be a good refresher so we can become coders.
And
I know about this.
I don't pretend to be a professional coder. I know my.
You know,
If you
you're-
asked me to code neurology, I would have no idea. I'd have to.
Yes,
So,
yes, exactly.
I appreciate the
Thank you.
opportunity to speak.
Yeah, thank you.
So it's Erica Brown is
Online.
online.
Yeah, both Erica and Lorraine. Hi there.
Good morning. So you're very wise to be in Burlington and not driving today, but we appreciate your taking time to testify today on H 766. Before we start, I'm just gonna scroll down. If we don't have your testimony as yet, but if you could get it to Kiki, and we'll have a record, that would be helpful. So
Okay, I can definitely do that.
So for the record, introduce yourself and then we would, like to hear your testimony.
Okay. Hello, my name is Erica Brown. I'm the Director of Patient Accounts for the Community Health Centers and the Federally Qualified Healthcare Center. We serve Chittenden and Southern Grand Isle counties. So thank you for having me today. Just a quick background, the Community Health Centers has been around since 1971. Understanding and addressing the needs of our community members regardless of financial status or life circumstance, which is in line with our mission. We currently care for 32,000 patients, providing medical, dental, counseling, and psychiatry services, among many other specialized safety net programs like our homeless health care program. On average, we have about 135,000 encounters per year, visits per year. And in a year's time, we submit on average, 178,000 primary claims alone per year. Blue Cross Blue Shield is one of our largest commercial payers. We do our best to give comprehensive care to patients and part of that is just recognizing the many social determinants that our patients face. So in a climate where access to care is already an issue, we do our best to meet patients' needs. The delays that we've experienced in payment due to the topic that we're speaking of with the administrative burden for visits does cause significant payment delays for our health center overall. The changes in the claims processing has had a negative impact in not receiving payments for services we render. It's delayed payments, as I've mentioned, increased administrative burden for billing and coding, and has delayed bills to patients as well as a result. We've lost staff and needed to add staff on top of that due to the stress of these payment obstacles. The delays in insurance processing are really not consistent. It's really hard to sustain. And, it's just adding a lot of cost and taxing the healthcare system overall. And just to clarify, so the bill does have to do with prior auths, and the second section is about the claims processing piece. So it's kind of a two-part bill. So Dr. Lynn and I are more speaking on the claims processing piece. Blue Cross Blue Shield is the payer where we're struggling most in terms of them enacting this, what's called cotivity denials. And it's that extra layer kind of prepayment that they enacted just over a year ago. So in talking about that, I'd like to just kind of first talk about the burden and impact on patients that this erroneous processing change, claims processing change has affected patients for sure. So with access to care, our clinic is one of a few in the area in Chittenden County, especially, that are accepting new patients. And we continue to absorb the delay or lack of payment. However, it does affect our bottom line when rendering services that we're not being paid for, 60, 90 plus days, or sometimes at all if the review is completely denied and needs an appeal. Also affecting patients are these delayed payments, especially patients who have what's called a deductible type of plan or a co-insurance type of plan, where they're not paying a standard copay when they come in for a visit. Their balance is basically their balance is noted once the claim finishes being processed, and the payer pays us and tells us what their final balance is. So, because it can take up to 30 days for the chart notes to be reviewed, that's after the 30 days traditional adjudication. It can take up to 30 days additional for Blue Cross Vermont plans and up to 60 days on top of the standard 30 for out-of-state Blue Cross plans to have these visits reviewed. If these visits are denied, we can submit for an additional review, just basically substantiating the rationale as to why we disagree with their denial, basically. But overall, the delay in payment affects patients because until the insurance plan, completes their review, they won't get a bill until that point in time. So it can be, they could have had their service and it could be 60, 90 days, sometimes longer for them to get their final bill if they have a deductible plan, which is kind of tough financially on patients. So those are some of the struggles that I think definitely impact the patient. Any questions about that? I was going to move on to how providers and staff are affected.
No, go right ahead,
Okay.
please.
So just provider burnout, primary care providers, do provide a cost savings to payers and keeping ER usage secured for those necessary services. So if primary care providers, do continue to be burned out and this, continued administrative tasks piling up, access to care may be a bigger issue on the primary care side and could result in patients visiting the ER instead of, their regular primary care, which is a fraction of the cost of ER visits. So without access to primary care, providers cannot enact care coordination and management to better manage patients' care and services to avoid unnecessary medical spend. So I think, again, thinking about the bigger picture and how all of this, downstream affects patients in the entire healthcare system, primary care is really necessary to, manage patients in their chronic conditions and keep them healthy, basically. We've experienced a lot of staff turnover as a result of really the administrative burden. I'll tell you that our biller who manages this, bucket of claims actually did leave about a couple of weeks ago. 15 years plus experience. She resigned and is out of the healthcare field entirely. So we're definitely seeing a lot of burnout from support staff to providers. And, obviously we don't want that. We already work pretty lean. And then we've just had the other thing that's caused issue is because of this administrative burden, we've needed to take existing staff and designate them to work all of these unpaid claims, which is taking them away from, we don't have extra staff to, bulk up and fill in the gaps. So when we take existing coders from their typical reviews, trying to, look at the overall and have to put them specifically on these additional denials that just continue to pile up, it does take them away from their other reviews. So we're struggling in that regard because we have a budget and we can't just hire additional staff to manage it. So those are some of the staff burnout or provider impacts. As an overall impact, though, to the health center, the delayed payment of 60 or 90 plus days beyond the standard 30 days after data service, I think that speaks for itself. When you add that up amongst many claims, it does start to hit the bottom line. If an appeal is needed, so if we send notes in for these unpaid services and it's denied, we can do the appeal, but that extends it even beyond the 60 or 90 days. Adding additional documentation. So the appeal then is reviewed by payer's cotivity or denial team. And it's if it's denied again, there's no other action for us to be able to get paid for it, even though we feel that it's accurate based on coding guidelines. So there's a little bit of concern in that regard in terms of subjectiveness and denials and payments in that regard. Also, the time to manage the administrative ask for these denied claims is extensive. The process of gathering the notes, Dr. Lynn spoke to this, it's a la carte, it's each one, and other associated documents, then emailing it to their designated address, which wasn't working for a long time and caused other issues. It's working now. Waiting for the response, tracking these all via spreadsheet, and then continuing to follow up. Since the decision does not always get returned, sometimes we do have to resend another whole round and start the process over again. So sometimes it's not just a 60 or 90 day. And again, the delayed bill to patients due to the above, it does affect the health center and the patients. And also the inability to reach the call center. So cotivity denial process was rolled out while and still the situation is a 2+ hour hold time to reach Blue Cross Blue Shield. And so the email options that we were provided as an alternative often results in not, these are not being received because again of email issues with Blue Cross. And then or the Blue Cross reps are behind, so they're behind, and then they're not responding timely. So then we have to retrack, and then it's a continuous, endless loop of emails. So we've found that this is just, it's frustrating because we're trying to track so much, and all the while they're not paid. And also the 2 hour hold time also is frustrating for patients because they'll ask us questions, we'll try to get answers, and we can't get through. And then we're trying the email option, and those aren't being dealt with timely always. And then the patient, we're needing to just say, like, maybe you should call them because the hold times are less for patients. But medical terminology and understanding the issue at hand is not always something the patient is comfortable explaining. So I feel like our level of customer service to patients is, not what it should be, but it's because our hands are tied with the inability to reach the payer. So those are some of our struggles. So we continue to care for our patients, of course, in a climate where margins are already slim. The additional work to gain payment for services rendered is really unfavorable for all. The payers who have to generate and send these weekly reports to us, and then, complete the manual review, patients' access to care, delayed bills, health center, carrying such a large administrative task and waiting for payment. All of that is really not helpful, I think, for anybody. In terms of the bill, in the section about the administrative tasks, I think that it gives some structure to, when new systems are put into place, some checks and balances. However, it doesn't sound like the manual review, like the hold payment until review is going to change as a result of the bill. So the administrative task is still there. I think the bill, does put some guidelines up when changes do take place. And that's how I understood the bill to read. If anybody else, may want to weigh in as well, but any questions about
No, this has been very helpful. And I think if you can send us your, written testimony, then we'll have it, to review. So, thank you very much. I do want to keep us moving along because we've got a long list of witnesses this morning, but we very much appreciate, the time that you've taken to
Thank you.
educate us a little bit. Thank you. So we're going to move on to, Lorena Fitzgerald of the Rutland Region Community Health Center. Yeah.
Good morning, everyone.
Good morning, welcome.
Thank you for the time this morning. My name is Lorena Fitzgerald. I am the Chief Operating Officer for Community Health Centers of the Rutland Region. I also happen to be a certified coder and grew up in the billing world. So I'm here to talk about more. Oh, I'm sorry. What?
I said, oh, you poor thing.
I love the billing world. Actually, I think it's very meaningful to paint the picture of the patients. Not only, again, I tell my practitioners when I train them or when I have trained them in the past that your note is a picture of a patient at that moment so that other providers could pick up care if you're not available. We just use that for billing, right? Billing takes the story you paint in your picture to get referrals or prior authorization or billing, but we want to make sure that we provide great care for patients. So as a coder, I can help a practitioner or they could be mad at me. You never know. It's part of our life. So I do want to add one thing to Erica's thing because I'm a little worried for our patients. And I don't live in the billing world anymore per se on a day-to-day basis, but there's these things called HSA, HRA plans in which, we pay into as patients, in which we can get money back to cover our deductible. I know personally, I'm on my husband's plan in which I cannot submit a bill past March 31st for the previous year. So if my practitioner is going to bill me for that service, I am going to have to pay for it out of pocket. I won't have access to those funds. We're at that threshold right now. I don't know if other health centers or practitioners are seeing that, but when you're talking about a 30, 60, 90-day delay out of end of year, that's going to negatively impact our patients' ability to pay their bills. That's my billing concern for patients. Community Health is a group that services our county, Rutland, so Madison County. We take care of 46,000 patients, and we have in between 200,000 to 250,000 patient visits per year. We do have primary care, behavioral health, and dental services, in which we have a core group of 6 internal referral specialists, and 3 of those work on prior authorizations pretty much most of their days, in which they're going through the processes of submitting into different software companies, not directly to Blue Cross Blue Shield, or it's through eviCore, or there's 6 different softwares that they use. On top of that, we also have nurses in each one of our clinics who work from 8 hours a week per 5 physicians, working just on paperwork for prior authorization. So we are lucky, I would say, to have a 50% pass rate for prior authorizations with no questions asked. One of the things that our referral specialists feel that are missing in our world, we have urgent, priority, and routine. Some of the softwares don't allow for that, so you just go in a bucket for prior authorizations to do like same day. So say, for example, if we have an acute issue on a patient and we're trying to get a prior authorization, our practitioners may send a patient to the ER if we can't get an answer, which is actually a higher cost of care for that ER visit. When there's a $2,000 bill just to walk through the door, and then there's another assessment by a clinician, and then they determine whether or not the test is needed. there's a burden, administrative burden on us to maintain. Of course, we have 8 different facilities. So the number of hours a week worked on for prior authorization, and I just want to be mindful that Medicare doesn't have prior authorization and Medicaid doesn't have prior authorization. So we're talking about commercial carriers for the most part, is high. Probably the referral specialist role at Community Health is the 3rd highest turnover position behind behavioral health, because of the fact that it's ever changing and ever frustrating, and the rules, while they're there, they're always not applied. There is a nurse maybe reviewing some stuff behind a practitioner, and our providers are just using their clinical judgment. They're using their clinical judgment for what they feel their patients needs. We purposefully do not ask our practitioners to look at insurances because they should treat every patient the same. So yes, they get stuff in their email boxes when there's things to be addressed by carrier rules. Our provider's core is to do right by our community, and that's what we want to do at Community Health. We have burnout on the provider side because they feel like they are playing an insurance game all the time. I think you heard that from the provider that was speaking earlier. They just want to provide good care for the patients. I think in the past, there have been other insurance companies that have reduced the prior authorization process and haven't seen an increase in overall costs. The patients have a delay in care because we're waiting. Patients have anxiety because they might need a test to rule out, not rule in. There's 2 different things. And they're calling the office every day, which increases administrative burden on our front office staff, and the patients are struggling. We feel that Community Health will not order more testing just because there's a rule. We want to provide good care for patients. I'm not sure if there's any questions about prior authorization.
Nope, this is fine. Just keep going right along.
Okay, all right, thank you so much. One of my mission this year for Community Health as a Chief Operating Officer is to reduce the administrative burden and also provider retention. I can tell you I've personally had conversations with practitioners who, this clerical administrative burden they feel is causing them to cut their hours back. In a world of shortage of practitioners, clinicians, RNs, we've had an RN just leave recently because she was always fighting the prior authorization on the medication side. It's hard when you're trying to maintain care for patients, and you're telling them in an exam room as a practitioner, your clinical judgment is this is what's the best for them based on what's going on. And then they get a call from us saying that the insurance company says that I can't treat you in this manner. And then they have to change. We can talk about step therapy, the therapy of the lowest cost. It could be you got to have 6 weeks of PT before you can get an MRI, or you have to go on a generic drug versus a name brand drug. That's huge anxiety for patients, as well as practitioners have to have more frequent visit or contact with a patient, which in an ever-changing and landscape of practitioner recruitment is hard when you know that you need 5 more practitioners to meet the needs of the community. And we have to use the visits. I think Dr. Lynn actually said she had to use her visits for things that didn't need to be clinically addressed at that time. I can tell you that some of the step therapies are frustrating for our practitioners because they have to do a prior authorization on a maintenance drug in which a patient should be on it or not have lab work or a visit for 1 year. Insurance companies are saying, well, I need to only have a 6-month authorization, and then you have to redo the authorization. Some medications that patients are on are medications that you don't check every month. And if you make a medication change, you can't check for 3 months. I'm going to use Synthroid as an example. It's a common drug. There's generics out there. But if you change somebody's Synthroid, you have to wait 3 months to be able to check to see the change in the levels of the blood, while the patient may be suffering. And when I say suffering, there's side effects. There's low-grade headaches, there's bowel changes, there's inability to focus. And then that impacts our patient's ability to go to work, to be able to maintain their function. We service our community, regardless of income, regardless of insurance. Some people don't have a voice. And so there's in the background, there's algorithms, which we feel we need, right? There's certain things that we need as far as guidance. And obviously everybody wants to keep costs low, for healthcare, for the local and also national carriers. But sometimes it's actually more harmful than helpful, especially when you're talking about a patient not being able to go to work or not being able to function, not to care for their children, the lack of food. There's so many things that we can do to a patient when they don't get their medications, or if they aren't able to get that next drug because of financial burden. Sometimes the jump in costs are $30 for 90 days versus 180, which they have to switch on and off, and they have to go get new medications, which is costly to the insurance companies and also costly for the overhead for community health in having to have staff be able to help and talk to patients through stuff. It does take, Erica talked about 2 hours being on hold to talk to somebody. We have the same functions on prior authorization and or for medications as well. I think that while some rules are justified, I think also practicing medicine is a science and an art, where practitioners have gone to school and they feel that their patient is in front of them and they feel like they're doing the best care for the patient. It's not about how to get paid. It's not about anything else. It's about taking good care of our communities, our fellow Vermonters.
Thank you very much. That's very helpful. And as I asked before, if you could please send your testimony in.
Of course.
What we're getting now is the background we need to understand the bill a little bit. We appreciate your time.
Okay, great.
All right. And good luck in Rutland. You're going to get lots of snow today.
We are going to get lots of snow today. Hopefully, they're already sending out emails about school cancellations.
Oh, wow. That's good for the kids to know. And the
Yeah.
teachers. Okay, good.
That is true. Thank you for your time.
Thank you. So we're going to move on, Nancy, to you. I think what we're going to do is we're going to hear from Nancy for about 15 minutes, we said, and then we'll take a little break. So just to alert the committee that we'll take a break. Yeah. They're always good. And our senators have been called to the House to testify in various bills, so everyone's going in and out. Welcome.
Good morning.
I like your sticker here.
You're allowed to change your mind. I'm gonna share my slides. And then I'll introduce myself this evening. That's terrific. Okay, we get from there.
We have this or even attended.
You should have, you have this,
I
yes.
think we do.
Okay, is that displaying? Okay, okay, great. So my name is Nancy Hogue, and I'm the pharmacy director for Blue Cross. I've been with Blue Cross for almost 2 years now, so it hasn't been that long. And I've been in front of this committee many times before in my prior role. For the 12 years prior, I was the pharmacy director for the Department of Vermont Health Access for the Medicaid program. So it's very nice to be back and see some old faces. So thank you for listening to my comments today. And I think, you know, in the 12 years that I did come in front of this committee, I've always tried to be very, you know, pragmatic in my comments, and so I hope that that comes across today as well. I will say, like, there really are only 3 parts of this bill that I feel are very important for the pharmacy provisions in the bill that are most impactful, and I'm just gonna focus on those. Largely, the bill, largely we can support or at least remain neutral on most of the pharmacy provisions in this bill. So, let me just set the stage. And I do want to say, like, the drug costs are, and the trends that we're seeing in, drug spend are incredible. Like, I've never seen such high trends over the last several years than I have ever seen in the 20 years prior that I've been kind of doing this work. So our total drug costs, were up almost 25% in 1 year between 2022 and 2023. And, I would say that is a combination of higher utilization, more people using more drugs, or same people using more drugs. And that the cost of drugs is just skyrocketing. So about 1/3 of that trend is because of utilization, and about 2/3 of that trend is because of drug costs. And of course, you're probably well acquainted with specialty medications. They're low use, so less than 2% of our members are on a specialty drug, but they account for 55 to 60% of cost. So they're immensely expensive. Wow.
We're working on it.
We do provide utilization management programs, and that, overall for 2023, that saved almost $39 million of that drug spend in 2023. And I just want to lay out what the components of that are. So prior authorization is the majority of that savings. And we do have some savings attributable to quantity limits. This is when we limit, say, it's really about sort of dose consolidation. So we want patients to take the fewest doses possible. Or there may be a limit on how many pills you can get in a month, let's say. So that's kind of what quantity limits are focused on. So it's to reduce waste.
If I could interrupt, my
Sure.
apologies. So this is new terminology for me. So the utilization management programs, these are 3 examples of utilization
That's
management
correct.
programs?
Yes.
Okay, thank you. Sure.
Yep. And then
So, well, since we stopped, maybe you're gonna get to this, but do you have, sort of your methodology for how you're calculating these savings?
I don't have the methodology detailed today, but I'm very happy to submit that later.
Yeah, that would be helpful.
So you want, like, how are these?
How do
things
you get to
calculated?
the 24.3 million?
Yes,
How can
yes.
you determine that?
Yep, we can submit that.
Okay.
And then step therapy is a smaller piece of the pie, but it's important. Step therapy for us is very focused. We only really impacted 2,600 members with step therapy in 2023. So it's very focused on a few drugs, and those drugs happen to be very high cost, high utilization drugs. So, as I said, there are a lot of provisions in the pharmacy components of this bill that we support. One of those is on the screen here. The bill says we shall not require failure on the same medication on more than one occasion. That's perfectly reasonable. And also when people move from one health plan to another, where we support retaining that information so that can be transferred from one plan to another, so that providers aren't having to do PAs all over again. So step therapy, there's only really 2 pieces of this that are troublesome. One is when we are not able to do step therapy for a drug in the same pharmacologic class. And I just the point that I'm making here is that, in some cases, in many cases, I would say, response to medication is very patient specific. So a patient can have a different effect with a different drug in the same class. So it doesn't necessarily mean you won't have an effect. That allows us to largely manage cost, because we want to be sure patients have tried lower cost medications in those classes before they can escalate to a much more expensive or specialty drug.
Are you seeing that that is not the case with provider prescriptions? That they aren't moving towards laterally rather than going to a.
Sometimes they do and sometimes they don't. I would say it's not across the board. I think most providers do try the lower cost products first, but we might ask that they try more than one. And I think that's where, where you're hearing some of that pushback is like, well, if the drug is in the same class, we believe it's worth trying a second product in that class before you move on to this more expensive antibody or biologic or specialty product. And then the only other provision in step therapy is the provision that says the insured is stable on a drug. I'll get to this a little later, but when rebates are very important, lowering net cost is very important. And if we can't switch patients when costs get lower in a particular class, so and remember, these things change every year. I'll get to this later when I talk about PAs, but when we negotiate contracts with manufacturers to lower the cost of drugs, those contracts change every year. So there are many drugs, I would say, that can be switched without a negative impact to the patient. And by this kind of ties our hands to do that, because it's saying you can't, once they're stable, you can't do anything about that. And would prevent us from moving patients to less expensive, equally effective drugs. I'm just going to shift over to PAs. This I wanted to point out, this is a comparison between Blue Cross and DIVA. And it's really just for context. We do about half of the PAs that Medicaid does. So we don't have nearly as many prior authorizations. Our denial rate is lower than Medicaid as well. It's about 25%, where DIVA's is about 28%. So this is for 2023. We had 3,720 denials.
Thank you, Madam Chair. So the bill, my understanding is that it would move private insurance companies to the same prior authorization standards as DIVA.
That doesn't apply to drugs.
Oh,
That's
you're
for the
just
medical.
got it. Okay. And can you go to your previous slide then?
Do the
Sorry.
Back arrow. The back arrow.
well,
Or you don't necessarily need to go to the slide.
Can you
My
do it?
question is about the stable. If a patient is on a medication and they're stable, it seems to me that you would want to keep them on that medication if they're stable, and that moving them onto a different medication may destabilize them.
Well, there's many cases where that's true, like
I'm
we
not a
wouldn't,
doctor, so.
obviously,
Yeah.
if this is especially true for mental health drugs, right? If somebody's stable on an antidepressant, you certainly don't want to destabilize them clinically or do anything to put that at risk. There are definitely provisions for that. I mean, we don't force situations like that. It's all about medical necessity and clinical appropriateness. So there are many situations where that doesn't cause a negative impact to the member, and those are the times when we're asking, for those switches. Like,
But shouldn't the doctor determine clinical appropriateness?
yes, they do, and, so let me give you an example, like, for example, I guess maybe the weight loss drugs might be a good example of this, where they're very, very expensive right now. We think the costs will come down as time goes on, but right now, these drugs are $1,300 to $1,500 a month. So if we are able to get a better price on a drug in the same class, so it's still one of the weight loss drugs, but it's, half the cost of the other, then we're trying to manage cost for our clients. And, that would be a situation where a member could switch. It wouldn't cause a negative clinical effect, unless the provider has a sufficient reason to believe that's true. We certainly take clinical notes and clinical, considerations. So, we're not asking for drugs to be switched that are clinically sensitive drugs. It's the drugs, there are a lot of drugs where that isn't true. Sorry, I don't have to go back.
No, you're fine.
We have it on
Yeah.
our, but you answered the question
Yeah,
based
you
on
did,
the
yeah.
language that's there, and we do have it on our, webpage.
Okay, thank you. Okay, just to shift to prior authorization, everyone knows, like, prior auths, the purpose of a prior auth is to assure clinical appropriateness, and patient safety, but also primarily, I would say, or equally, as important to, lower premiums, lower healthcare costs through manufacturer rebates. As I said before, those rebates are negotiated annually. And manufacturers are lowering the cost of those drugs through these rebates in order to get some kind of preferred status on a formulary, to get sort of, some preference, if you will, for their drug on the formulary. And that's the way it is for every health plan in the country. That's the way it is for Medicare, Medicaid, doesn't matter who you are. That's just how the world works. Well, that's how that's how the drug payment system works, I guess I would say.
In America.
Yes, exactly. So prior auth criteria are developed through a review of evidence-based literature. We certainly look at manufacturer information that was submitted to the FDA. So we're looking at studies that was submitted for FDA approval. And then it's reviewed typically by a P&T committee, similar to like DVIS DOR board, for example. It's a panel of physician and pharmacist experts, and they're looking at all that clinical information to determine that whatever the criteria is for coverage, that is clinically rational and reasonable. So that's kind of how PA development occurs. The timeframes in the bill are not a problem for us, where we support those timelines and we are compliant with the timelines. And I've just listed the turnaround times here for our standard and urgent PA turnaround. So there's really just one provision here that is particularly problematic, and that's the provision that says that the PA, if the treatment continues for more than a year, then the plan would not be able to do a PA for 5 years. And 5 years in the drug world with manufacturers is a very long time. A lot of things change in 5 years. We have new drugs that come to market. We have many price changes that occur. We have generics come onto the market, biosimilars come onto the market. So that seems like a very long time to not be able to make a change. And so, regimens really should, sometimes there's a clinical reason you want to reevaluate after a year. Sometimes it's cost reason because the costs do change frequently, very frequently. So I just gave the example of the weight loss drugs here as well, where we had 1,000% increase in cost in those medications. And as more drugs come to market in that class and we're able to drive the cost down, we certainly want to have a mechanism to be able to shift to lower cost products. And this would restrict our ability to do that. And I'm going to stop sharing, and I just have a couple of closing comments, if I may.
Absolutely.
Here we go. Am I not displaying anymore?
You're not displaying.
I'm gonna refer to my notes so I don't forget anything. So as I said, earlier, our sector protocols are very targeted. Again, we only targeted 2,600 members out of the 100,000 plus that we have pharmacy benefits coverage for. So it's a small patient population. And the goal is to direct the utilization to lower cost alternative medications, including generics and biosimilars, which biosimilars are really going to explode over the next 5 years. So that's going to be a very important component of cost management. We did hear the assertion that this language passed in Massachusetts and New York and had no cost impact. However, that was 6 to 8 years ago, and we have seen a lot of new drugs in the last 6 or 8 years that are very impactful to cost. As I said earlier, like most of these are specialty drugs, but not all of them. The diabetic class has really gotten very expensive and grown tremendously, as well as as I said, the obesity drugs is another good example of that. So, what happens, I think, when costs get very high, plans that are self-insured can choose not to cover drugs as a strategy to avoid that cost. And I think we saw in the news recently that the North Carolina State Employee Plan decided not to cover the weight loss drugs anymore because it was just a budget buster for them. So, we certainly don't want to go down that path. And we're certainly not trying to undermine the decisions that are made between a doctor and patient, but we do have unique visibility into the cost, which providers don't. And so if there's a way that we can help providers understand cost differential, and also like members' out-of-pocket expenses, if they can't afford medication, it's going to be an adherence problem for them as well. So if we have a way that we can encourage lower cost medication, we would like to be able to continue to do that. As I said, we support a lot of the pharmacy provisions in the bill, including retaining PAs for members that are switching plans, or not having to do them more than once for the same, not having to do step therapy more than once for the same medication. And so I hope that you'll consider my comments, and I'm happy to answer any questions.
But we will consider your comments.
Thank you. I appreciate that.
Let's have a couple questions and then we'll take a break.
Thank you. So I'm looking at your slides, the provision about the 5 years. What was your suggestion is just to remove it completely? Yeah. Is there another what is the current law? Is there any time period? It's just
Senator, I think what we'll do is this is a very good question.
I'm just curious what you have.
Good.
What your timeline is you're suggesting, just like no timeline or?
Oh, most of our PAs are 1 year.
1 year.
We do have some drugs that are shorter than that, like 6 or 7 months. And those are typically drugs where you want to check on efficacy at a certain point in the therapy. So there are a small number of drugs where we have slightly shorter, but I would say the great majority are 1 year.
Okay.
So I have a question too, regarding the Drug Utilization Review Board. To what extent do you utilize their information in making your decisions?
So we use the Pharmacy and Therapeutics Committee that is managed by our PBM. So we don't use the DIVA DUR board in our decisions on the commercial side and the commercial plan.
Okay, thank you. And we may come back with more questions, so we appreciate your expertise in this area.
Thank you very much.
As committee, we're gonna take a break, a 7-minute break. So at 25 after, we'll be back.